Good morning. My name is Nicholas Hanley, and today I'm going to be discussing with you electrocardiogram correlation to cardiac events. The objectives for this presentation are the following. Number one, to explain what an electrocardiogram is and how it works. Secondly, I'd like to identify and explain the parts of an ECG. Next, we're going to compare and contrast the various abnormalities that can be found on ECGs. And then finally, explain some methods used to detect heart disease. So, what is an electrocardiogram? An electrocardiogram is a recording of the heart's electrical activity, but instead of taking it directly from the heart, we're picking this activity up um, via the electrodes on the surface of the body. So, heart electrical activity from body tissue is what's being picked up. When we do this, there are three important points when we're talking about ECGs. Number one, it is not a direct recording of the actual electroactivity happening in the heart. We're taking the electrical activity that's present in the bodily fluids from that cardiac impulses that reach the body surface. Okay, so not a direct recording. Number two, it is a complex recording. It represents the overall spread of the activity throughout the heart, with both depolarization and repolarization occurring. So we are not measuring a single action potential at a single point in time. It is a continual thing. So some fibers may be depolarizing, some might be repolarizing. There should be a pattern to it, but it is a summation of all the underlying or undergoing action potentials. So immediately after the SA node fires, we will see atrial cells undergoing action potentials while ventricular cells are still in the resting potential. And then at a later point, the ventricular cells are firing where the atrial cells are repolarizing. So there's lots going on there. So it's not a very simple recording. There's lots going on. And finally, the third point is that we are doing a comparison here. So the recording represents comparisons in voltage detected by electrodes at 2 points on the body. So again, we're not measuring the actual potential. We actually use 12 leads. The image here shows the 6 that are placed on the chest. The other ones are placed on the arms or the legs, and we use these to get a comparison. So now the parts of an ECG, if we're looking at these, there's three main waveforms that we view or look for on an ECG. The first is our P wave here. This P wave represents atrial depolarization. Now, we do not see anything on here about the SA node firing. That's too small of an impulse for us to detect with our electrodes. But this is the atria depolarizing. So we get a nice good wave for that. Next, you see the QRS complex. This is ventricular depolarization. Now, typically after we depolarize, we need to repolarize, and we don't see atrial repolarization on here because of the timing of it. Atrial repolarization occurs as the ventricle is depolarizing, so the QRS complex masks the atrial repolarization. And finally, we have our T wave here at the end. The T wave represents our ventricular repolarization. So we get all those parts that we need there. So on a normal EKG, these are what I'm looking for, these three main waveforms. Now, deviations from normal. Now, we know what it's supposed to look like, but abnormalities do happen. So some of the abnormalities that we pick up on here are rate abnormalities, so increase or decrease in rate. We have rhythm abnormalities, which we'll talk about in a little bit. Those are things like atria firing twice before the ventricle does, or there's a missing ventricular contraction. So anything like that is a rhythm abnormality. And then cardiac myopathies deal with the damage to the tissue of the heart. So we'll look at those as we move through the presentation. Regardless of what's going on here, the patterns of the ECG do help us diagnose disorders. By knowing what's going on, what the electrical activity looks like, it leads us to what the mechanical activity should be doing underneath. Okay, so if we're talking abnormalities in rate, again, we can use the specialized calibrated paper of the ECG to determine the rate. So the distance between two consecutive QRS complexes, this distance gives us the time. So that's 1 heartbeat, and we can multiply it out to figure out how many beats per minute that would be. In this upper image here, You can see the QRX complexes are pretty close together. There's no spacing really between them. This is what we would call tachycardia. So this heart rate is going to be increased. To be classified as tachycardia, we're talking beats over 100 beats per minute. Okay, the bottom picture, you can see that the beats are spread out a little bit. So this is what we call bradycardia, or a decreased heart rate. In the case here, to be considered bradycardia, the beats would have to be under 60 beats per minute to be considered bradycardia. So those are the two abnormalities in rate we can pick up on an ECG. Now, we're going to spend a little bit more time on abnormalities of rhythm. There's just a little bit more to talk about here. We know that to signal the heart to contract, the SA node fires an impulse, which goes to the AV bundle, or AV node, which is delayed a little bit and then travels down the bundle of His to the Purkinje fibers, and all that process causes the heart to contract in a particular rhythm. So when we're talking rhythm, we're talking about the spacing of the ECG waves and the various parts of the ECG waves. So we want to make sure we're in a particular rhythm when we look at that. So any deviation from normal in the rhythm we would call an arrhythmia. And depending on what the arrhythmia is, it can affect the heart rate because we're affecting the spacing between the two consecutive QRS complexes. That affects the heart rate. These arrhythmias can be caused by several things. One is an ectopic foci or focus. What this means is the SA node is supposed to start this electrical pathway, and it's supposed to travel down to the AV bundle and all that, like we talked about. If somewhere along that pathway a cell randomly causes to contract, that would be an ectopic focus. It's originating from somewhere that's not the traditional spot. We can also have SA node alteration. If there's something here and it's firing too fast or too slowly, or it's not being able to send the signal, it's not getting to other parts. So we can do SA node alteration or even conduction interference. If the signal is not getting from the SA node to the AV node, or it's getting there but it's not being conducted down, that can lead to arrhythmias as well. Okay, the first arrhythmia we're going to look at is premature ventricular contraction, or PVC. What happens here is normally it originates from an ectopic focus, so somewhere randomly along the conduction pathway for the ventricle, a signal gets sent to contract, and it puts it out of sync with what the typical heart rate would be. So if we look here in the picture, we have one good heartbeat, second good heartbeat, and then the ventricle fires here prematurely. So this is a PVC right there. With atrial flutter, what we're seeing is we see these, this is where the P wave would typically be, and we see kind of three bumps. So the atria is rapidly repeating the depolarization before we get a ventricle contraction. So rapid but regular sequence of atrial depolarization, that normally happens, or could get to the point where it could cause up to 20 or 200 to 380 beats per minute from the atrial part of the heart. That is a lot of speed to go with there, and the AV node just cannot keep up with that. So even though the atria is sending the signals, because of the repolarization and everything, and the refractory period that the ventricle needs in order to reset everything, every atrial signal is not going to be turned into a ventricular signal. So we get what we call a 2-to-1 or 3-to-1 rhythm. What that means, for every 2 atrial impulses, only 1 ventricle, or for every 3 atrial impulses, only 1 ventricular impulse is produced. So 2-to-1, 3-to-1 rhythm. So in here we have a 3-to-1, so there's 3 atrial pulses, and then we get 1 ventricular. Even though they're not equal, rapid increased atrial signals can lead to increased ventricular contraction. So if the atria is trying to fire 380 beats per minute, the ventricle is going to, even at 2-to-1 or 3-to-1, that's going to fire a lot more often than it's supposed to. So that leads to increased ventricular contraction. And if the ventricle is contracting too quickly, it's not filling properly with blood, so that's going to reduce our cardiac output, and that could lead to unconsciousness and death if it's not corrected. With atrial fibrillation, a little different. In this case, what's happening is We still have rapid, irregular, uncoordinated um, depolarization of the atria with no definite P waves. So atrial flutter was here that we just talked about. It was still pretty consistent. If we look at atrial fibrillation, sometimes the wave is missing, so we don't even see it, or it's really minor. So it's irregular in that fact that it's not firing consistently. Because we're doing that, as you can see, the spacing between the QRS complexes is a little not consistent here, a little random. So irregular ventricular contraction occurs, even though the QRS waveform is normal in shape, it's just more sporadic in when it happens. Again, this causes a variable filling of the ventricles, which could really lead to cardiac or reduced cardiac output. And another topic it talked about here in the reading was a pulse deficit. Because the ventricle is not able to push out as productive of a impulse as it typically does, it could be not strong enough to where if we try to detect the pulse at the wrist, you don't detect the pulse even though the heart is beating. So the difference between the actual heart rate and the pulse picked up is different, and that's the pulse deficit. Okay, and the next arrhythmia is ventricular fibrillation. Basically what happens here is it can be a very serious abnormality. Multiple impulses are traveling erratically in all directions around the ventricles. So we have complete uncoordinated contraction of the ventricles here. And as you can see, it's really hard to detect any specific pattern in the ECG. Because the ventricles are erratically pumping, we're not pumping sufficiently. And if we don't restore that rhythm, death can occur in about 4 to 5 minutes if the brain's not getting the oxygen it needs. So with this rhythm, cardiac compressions that you see in CPR or even AEDs, the electrical defibrillation, those the cardiac compressions keeps the heart beating in a semi-regular way so that we can get that blood to flow. And the electrical defibrillation kind of resets the heart to allow the SA node to try to take over and reset the proper signaling. Next thing we're looking at is heart blocks. Heart blocks arise from defects in the cardiac conducting system. So if the signal is not happening properly from the AV node or the SA node to the AV node, we could see these things. So in most cases with heart block, the atria still beats regularly, but the ventricles occasionally fail to be stimulated and thus do not contract following atrial contraction. So there's a blockage of the signal from the atria to the ventricles, thus heart block. If this happens, again, the rate at which this happens can cause a decreased ventricular rate. Sometimes the impulses only every 2 signals produce a ventricular contraction, or every 3. So we recognize these as 2-to-1 or 3-to-1 blocks, not to be confused with the 2-to-1 or 3-to-1 rhythm that we saw with atrial flutter. So this is with block. Heart block can be complete when there's no signal reaching the ventricles. So if there's something with the AV node and it's not sending that signal, we have a complete blockage. It can characterized by complete dissociation between atrial and ventricular activity, with atrial pulses not being conducted to the ventricles at all. When this happens, the SA node governs the atria, but the ventricles kind of start generating their own impulse, and that rate is normally slower than that of the atria. If we're looking at the ECG, your P waves would semi-seem a normal rhythm. The QRS and T waves also occur regularly, but there's a disconnection between them. So that could influence the way the heart's pumping and limit the effectiveness of the pump. Okay. The last category that we're going to look at are cardiac myopathies. In a cardiac myopathy, this is where there has been damage to the heart muscle. So we call it myocardial ischemia, or MI. That's where we have inadequate delivery of oxygenated blood to the heart tissue. If we have that inadequate supply, it can cause the tissue there to die or necrosis to occur. Um, and that typically happens when the blood vessel supplying that area either ruptures or is completely blocked and no blood is getting through. In this case, what we call that is an acute myocardial infarction or a heart attack. What we normally see here is an abnormal QRS waveform. When part of the muscle becomes necrotic, we see an unusual one there. And we also, those damaged heart muscles will release characteristic enzymes into the blood, which is an indicator of heart attack, and the amount of those enzymes can tell us how the extent of that myocardial damage. So if we look at the normal heart here, and we're looking at this view here, so we're looking at the left ventricle and left atrium. In a normal heart, we have a specific thickness. If we have hypertrophic cardiomyopathy, we see a thickening of our left ventricle. Restrictive cardiomyopathy, it's just the ventricle's not opening as much as it should. And then dilated, we have a wider. So we have kind of atrophy of the ventricular tissue here, and it's not being able to pump what it needs to. Now, detection of cardiac conditions. The big test stressed in the book was a stress test, which is also known as a graded exercise test. In the stress test, what happens is we're trying to identify or diagnose, quantify heart or lung disease, and we could also use it if we're trying to evaluate our functional capacity. So if I'm having chest pains and stuff, I might get this done to see what type of cardiac disease I have. If I'm an athlete or something, I might want to just see what my full potential is. So I can run this test for non-medical reasons. But so stress test, what normally happens is the person either runs on a treadmill or an exercise bike, and as the test goes on, the task gets progressively harder. They increase the rate or the incline or the tension on the bicycle. And as they're doing the test, the person is connected to an ECG, and that's continually running. And every minute they do take their blood pressure. We're going to continue doing this until a specific workload is achieved. Physiological symptoms like chest pain or something start occurring, or the subject is just too tired to continue. So with the stress test, we can use that to see the ECG, what's going on. Some other tests are cardiac catheterizations, where they extend a catheter up through the blood vessels and normally the femoral artery up there to detect and see what's going on. We can do cardiac CT scans or cardiac MRIs, a coronary angiogram. The other one that I found interesting was a coronary calcium imaging. When blood vessels become blocked with plaque, the body's natural response is to release calcium there. So with the coronary calcium imaging, what they do is they use a CAT scan, computerized axial tomography scanner, and they measure the amount of calcium that's present in these coronary arteries, coronary vessels. As we're looking at that, the more calcium that's there gives us information about what's going on. Obviously, the more calcium, the more potential blockage there is. And then so it measures both the amount of plaque present as well as the stability of that plaque, where it's at. Is it free floating, which could be bad. Interesting how we could do it. It's a rather inexpensive test compared to some of the other ones. So interesting to see how this plays out in the future. Again, to talk about our objectives, we wanted to explain the electrocardiogram and how it works. We wanted to identify and explain the parts of the ECG, compare, contrast the various abnormalities that can be found, and then to explain some of the methods used to detect heart disease. Here are my references, and thank you for listening.